I'm now going to leave behind the disorders usually diagnosed in childhood and jump with both feet into axis 1. We're going to begin with axis 1. That means we should begin with the big diagnosis, schizophrenia. Now I have to confess to you, I kind of like schizophrenics. No, you're right, I don't want my sister to marry one, but I think they have their own style, their own unique way of being in the world. How do you recognize that the person you're talking to is schizophrenic? Oh my goodness, they have one, bizarre delusions. Delusions are false beliefs not culturally verified. Delusions are things you think where other people around you don't agree. Bizarre delusions are, well, just an extension to that. So concretely, if you think there's aliens orbiting the Earth watching what's happening down here on the planet, that's a delusion. If you think these aliens have a base on the dark side of the moon where they're watching you particularly, and that if you hold your hand just so and wear a certain kind of metallic metal inside your cap, they'll give you all the answers for the step 1 exam. Now we're talking about a bizarre delusion. Second key symptom is, note, auditory hallucinations. As far as you're concerned, certainly for step 1, visual hallucinations are a rule-out criterion for schizophrenia. It's auditory hallucinations we look for schizophrenics. Please also note that although 75% of schizophrenics have these auditory hallucinations, 25% do not. And so if you're waiting for auditory hallucinations to make the diagnosis, be careful, you're going to miss 1/4 of the cases. I want to have you call to mind a movie you might have seen, a rather famous movie called A Beautiful Mind, featuring an actor named Russell Crowe. Beautiful Mind, Russell Crowe is representing a real-life person named Nash, who was schizophrenic. What's the one thing they didn't do right in that movie? They gave the Nash character in the movie visual hallucinations. The real-life Nash character only had auditory hallucinations. Why did they give him visual hallucinations? 2 reasons, really. 1, because they thought it'd be more interesting for you to watch, people than just hear voices. And 2, they were, by giving you those visual representations, able to kind of suck you in and gave you just a small taste of what it's like to have a certain kind of schizophrenia. There's a point in the movie where people are chasing him down the stairs, guys in white trench coats, and you're really not sure, are they the good guys or the bad guys? Who are they? That's sort of just a little taste of what it's like to have this kind of schizophrenia. Again, schizophrenics really were looking for auditory hallucinations. Blunted affect. Blunted affect, you simply don't have any expression, you're just flatline like this. I've had faculty members like this, they're very interesting, don't you think so? That's blunted affect. And loose associations, where you jump from one thing to the next in a way that might make sense to you, but it's hard for other people to understand. Thursday, yes, Seattle bicycle. That would be an example of loose association. Made sense to me. If you didn't get it, sorry about that. Deficiency in reality testing. Stop thinking about schizophrenics as just living in a world of their own. That doesn't quite cut it. Instead, think about them as living with 1 foot in our world and 1 foot in their world. Your job is to work literally with the foot you got. Disturbances in form and content of language and thought. Form is how it comes out. Content is what we're talking about. So, if I think I'm Napoleon, is that a form or content issue? Well, that's a content issue. Napoleon, a noun, a content issue. If I have loose associations, if I have words that don't make any sense, if I have chopped up sentences, that would be the form of language. And changes in psychomotor behavior. This is actually more important than the press that it gets. One of the earliest incipient signs of schizophrenia is schizophrenics lose the natural gracefulness of motion that most of us have. As I speak to you, there's a rhythm in my voice, my head moves, my hands gesture. There's a natural, biological, schizophrenics lose this early on. It's called dysprosody. They've lost the natural prosody, which is what we have as we talk and interact with each other. Again, if you can think back to the movie A Beautiful Mind, the Russell Crowe actor who portrayed Nash did a very, very good job. He did not just portray for you the florid symptoms of schizophrenia, hallucinations, delusions, he also got the movement issue right. Early in the movie, if you can remember, think about him walking across campus, chasing the birds in the quadrangle. He moved funny. He had an odd, non-human, sometimes almost robot-like gait. I have to confess, at that point in the movie, I turned to the person next to me and I said, my God, he looks schizophrenic. Because once you've seen it, you'll recognize it when you see it again. Let's spend a moment doing a little differential diagnosis. How do we separate out schizophrenia from schizophreniform? Well, that's fairly easy. It's about time. If you have all these schizophrenic symptoms, or some combination of them, less than 6 months, we call you schizophreniform. Once it's over 6 months, we call you schizophrenia. So if I have someone in the hospital for 6 months, they're schizophreniform for that part, and then 6 months I pull the chart, cross off schizophreniform, and write in the right brand of schizophrenia. Brief psychotic disorder. This one's fairly easy too. You have psychotic, that is schizophrenic-type symptoms, lasting from 1 to 30 days, and then, critically, full return to former functioning. If somebody meets you, they would never know you had these schizophrenic episodes. There's no tail, there's no lingering weirdness, if you will, to focus on. Onset of schizophrenia is later for women and earlier for men. Onset for men tends to be in the 15 to 25 range. For women tends to be the 25 to 34-year-old range. Using the society as a whole, the prevalence is about 1%. And that's cross-cultural. Wherever you go in the world, you're going to find roughly 1% of the population schizophrenic. High in the mountains, over the sea, 1% of the people is schizophrenic. Isn't that nice to know? But we also find much higher rates of schizophrenia and low socioeconomic status. And for the following reasons. One, well, remember, SES is computed by education plus occupation, right? And so if you're schizophrenic, completing that education, holding on to good occupation, that becomes a little bit more difficult, don't you think? Second, schizophrenics, as we'll see in a moment, tend to reproduce themselves. And so you tend to get an accumulation of schizophrenics in the low SES echelons. Although you might have 1% of the total population schizophrenic, in the low SES echelons, you may find that number to be as high as 5, or some people have argued even 10%. Half the schizophrenic patients attempt suicide. 1 in 10 end their lives by suicide. And just over half of schizophrenics do not live with their families, nor are they institutionalized. Where are they? All right, you're thinking out on the street, aren't you? Come on, admit it to me. You're thinking about all the street people you walk by. Well, you know what? Some of them are schizophrenic, but I have to tell you, a lot of those people you're thinking schizophrenic, you're wrong. They're schizotypal, a personality disorder we'll talk about a little bit later. Now, if the person standing on the street corner is talking to someone that's not there, swatting at flies that aren't around them, you got me. That person's probably schizophrenic. But those really weird people in weird dress you see on the street every day, they're likely schizotypal, not schizophrenic. So where are these schizophrenics? Well, some of them are your fellow residents. Some of them will be your attending physicians when you're in residency training. The two best emergency room physicians I've ever met are both schizophrenic. How do I know that? They've told me they were. But they're both very, very good at what they do. The reason I'm having this conversation is not to tell you schizophrenics make the best doctors. That's really not the message. But it's to get you to rethink what you might see as the course of schizophrenia. Now, I'm not saying most schizophrenics go on to lead great lives, but I am suggesting some do. And you have to expand your sense about what the prognosis is. What do we mean by positive symptoms versus negative symptoms? Well, positive symptoms are add-ons, the things that schizophrenics have that we don't have. Negative symptoms are deficits, the things that schizophrenics lack that we have. I don't have auditory hallucinations. Schizophrenics do. That's a positive symptom. I don't have bizarre delusions. Schizophrenics do. That's a positive symptom. Positive symptoms seem to be connected to activity in the dopamine receptors. Negative symptoms. I care. I really am involved in what goes on around me. Schizophrenics aren't. That's a negative symptom. I have emotional expression. Schizophrenics don't. That's a negative symptom. I move freely and have rhythm. Schizophrenics don't. That's a negative symptom. Negative symptoms are connected to the muscarinic receptors. Schizoaffective disorder. What I really need you to know about this label for step 1 is simply this. Don't pick it. It's probably not the answer. Schizoaffective disorder, these are people that have some of the signs and symptoms of schizophrenia along at the same time with some of the signs and symptoms of mood disorder. It is too subtle a diagnosis to really expect you to make at this level of the exam. Don't pick it, pick something else. We've been able to, by research and clinical experience, come up with notions of some schizophrenics more likely to get better than others. Predictors of good prognosis include if you're paranoid or catatonic, you're more likely to get better than if you're undifferentiated or disorganized. If you have a late onset, so women who have the later onset have better recovery rates than men do. If you have a quick onset, one day you're fine, bang, next day you're schizophrenic, I know that's frightening, but prognosis is much, much better. If you have a lot of positive symptoms, we seem to be able to treat them better. If you have no family history of schizophrenia, if you do have a family history of mood disorder, and if you lack any structural brain anomalies we're about to talk about, you have a much, much greater chance of recovery, better prognosis. Most of you sat down here already knowing the schizophrenics is at least in part a hyperactive dopamine problem. We've known this for, half a century. We've known that dopamine is involved because, well, the primary thing that cements that idea is when we give drugs that reduce dopamine, we get symptom relief. But there's some other neurotransmitters I'm going to spend a moment chatting about. Once dopamine's involved, you know that serotonin is going to be involved too, reminding you that dopamine and serotonin are sort of inverse in the frontal lobes. In fact, increasingly, we're coming to think about schizophrenia not as just hyperactive dopamine, but as an imbalance of serotonin and dopamine, especially in that frontal lobe area. We know that serotonin is involved for the following reasons. One, there are people with particular genetic deficit having to do with a serotonin receptor, and those people are much more likely to be schizophrenic. Two, when we give people drugs like LSD, that we know have their primary action on the serotonin receptors, people have symptoms that mimic a lot of what we see for schizophrenia. But three, the real reason we know is our newer, the so-called atypical antipsychotic drugs work on serotonin or serotonin and dopamine in combination. Again, we know serotonin is involved because pharmacology that affects serotonin provides symptom relief. But I also want you to be thinking about glutamate. We think glutamate is involved, and there's some debate about this, but not primarily as the key neurotransmitter, but by cascade. Simple way to think about this is you're schizophrenic, your dopamine neurons are firing, and then by cascade, the glutamate neurons are also firing, and you get, over time, the brain that in some sense burns itself out. You get onset of what we call excitotoxicity, which over time starts actually killing off brain matter, killing off gray matter, killing off white matter.
Schizophrenia, hospitalization is required if the patient is very aggressive or is actively acting on their delusions in a dangerous fashion. Antipsychotics are frequently used either alone or sometimes we'll use them in combination with a mood stabilizer or antidepressant depending on the symptoms of the patient. But antipsychotics are the most important. Psychosocial treatments are very helpful, such as family education, social and vocational skills training, roommates, daily activity. These guys do very well if you give them a similar daily activity every single day and they have a schedule. They don't do well with change. They don't do well with increased emotions. They can even work in some jobs. A lot of paranoid schizophrenics actually work as security guards, which you can see is actually pretty helpful because they're always kind of on watch, so they would actually make pretty decent security guards. But you also need to be aware, and this is an important new assembly point, that about 10% of schizophrenics will commit suicide. So just like with major depression, you must assess their suicidality. In any psychiatric patient, always assess suicidality. Board question. Next we have schizoaffective disorder. So what schizoaffective disorder is basically, this is someone who has schizophrenia or psychosis a majority of the time, but they also have a component of mood alongside with the schizophrenia or the psychosis for a majority time as well. So for example, if they've been psychotic for a year, they will also be feeling depressed for 8 months out of that year. But there must be at least a 2-week period where they are psychotic without any mood symptoms. So that is what schizoaffective disorder is. And a differential for schizoaffective disorder would be mood disorders such as bipolar disorder with psychotic features or major depressive disorder with psychotic features. These guys usually present to their mid to late 20s. They have all the similar symptoms of schizophrenia, but the addition of either a manic episode or a depressed episode. And again, it has to be for a significant portion of the psychotic portion. And you'll treat them just like you do schizophrenia, with hospitalization if necessary. And you'll treat them with a mood stabilizer, an antipsychotic, and antidepressant as needed. Now, schizoaffective, because it has an affective component, which means it has a mood component, has a much better prognosis than schizophrenia. Next, we have schizophreniform disorder, which they meet the same criteria as schizophrenia, but you have to look at the time period. That's the only thing that differentiates this from schizophrenia. So it has to be at least for 1 month, but no more than 6 months. And there's typically less social withdrawal with schizophreniform disorder. You treat it the same way that you treat schizophrenia, and eventually you might not need to keep them on medication for a very long period of time. Brief psychotic disorder is the same symptoms of psychosis with the delusions and the disorganized speech and behavior, but it only lasts between 1 and 30 days. There may or may not be any kind of acute stressor, and if it occurs within 1 month of having a baby, it's called postpartum psychosis. For this, if the patient is in acute danger to self or others, you can treat them with hospitalization. You might need a short-term treatment with antipsychotics. Otherwise, the disorder is self-limiting and will go away by itself. So the differentiating factors between schizophrenia, schizophreniform, and brief psychotic disorder is the time periods. Delusional disorder is a chronic disorder, and to differentiate this between schizophrenia is that the delusions are not bizarre. Whereas in schizophrenia, the delusions are very bizarre. Like, they will think that there is electricity coming out of their head, or they will think that God is talking with them, or it'll be very bizarre. You know that it really can't happen. The FBI is only following them because they've done something wrong. So those are going to be the very, very bizarre delusions of schizophrenia. Whereas a delusional disorder patient won't have bizarre delusions. They will have much more simple delusions, and you might even think to believe them. And it might be something like, I think my wife is cheating on me, my husband is trying to poison me, and actually you might not even notice that a patient has delusional disorder because they actually walk around in public and you won't notice it unless you happen to stumble over it in conversation. They have to have the delusion for at least 1 month, and the delusions are circumscribed. They're about that one particular thing they have the delusion about. And usually no functional impairment other than what's associated with the delusion.